Hello, everyone. Today we are going to be looking at an overview of Public Health 88S Innovations in Public Health and the Impact of Technology. I've been so lucky to be able to develop and teach this class this past quarter, and I just wanted to spend a few moments today to do a quick overview on the past 10 weeks and tie together a lot of the concepts, the frameworks, the topics, the technologies that we looked at. So for our spring quarter overview, I'm going to go week by week, covering the concepts, the technologies, and the issues that we discussed. Starting with week one. Week one, we just looked at what public health is, defining that, and frameworks around it. So public health, we said, was public health promotes and protects the health of people in the communities where they live, learn, work, and play. And that's pretty straightforward. We looked then at the determinants of health. So these are the things, the factors that lead to someone's health outcomes. And we focused on four overarching categories, which is just the biological factors, someone's genes, then someone's health behaviors, and someone's social or societal characteristics, and finally, the access they have to health services or medical care. We then looked at the framework of the ecological model. So whenever we're creating an intervention or approach to seeking a solution in public health, we can apply a model like the ecological model to describe where we're going to be targeting, who we're going to be targeting, and how we're going to be targeting them. The model that we looked at, this ecological model, has five main components of where you may develop your intervention and who you may develop it for. And whenever you're designing an intervention, like we discussed, it could fit either one of these or multiple of these avenues or these angles. So first, we have just the individual level. So this is when you're targeting someone specifically, at the individual level for their individual health. Then you have the interpersonal level. And this is when you're targeting the people around a person that you're trying to target for their health. Then you have organizational approach, and this is when you're looking at where someone learns, their school or where they work, their job. You have the community level, and this can be described in many different ways, but really the community is where the area and the people that a person are around. And finally, there's the public policy level, and this is when you're looking at governmental approaches, city, state, country, worldwide, and having policies in place that promote certain health behaviors. And then in the next week, week two, we then looked at the medically underserved communities. And the approach for this course was not just looking at technology and public health, but we wanted to look at specifically the way that technology has affected underserved communities, because looking at it through that lens really can elicit the importance of the care that goes into making sure that your approaches are really careful in being right for that specific community. And also medically underserved communities have historically had certain issues that haven't been resolved. So technology, as it's innovating throughout the field of medicine and public health, we see the effects and impacts that it has on these underserved communities. So we wanted to define a medically underserved community, and one of the broad ways that we looked at it was in defining an underserved community is that they have few primary care providers, they have high infant mortality rates, they have high levels of poverty, and they have a higher level of elderly in that population. Looking at the determinants behind a healthcare underserved community, we look at healthcare access as one of the main tentpoles. And healthcare access can be approached in a list of fundamental ways, one of which is insurance. We're looking at the causes for why healthcare access could be decreased. We said that insurance, the lower insurance rates, is a big reason that people may not go out and seek care if they're not covered. And the Affordable Care Act expanded access for health insurance, but there's still high rates of uninsured people throughout communities, particularly among recent immigrants and people who have lower fluency in English. Another graphic we can see here, we can see that people who are considered poor or near poor, which is below the poverty threshold or within 1 to 200% of that, are much more likely to be uninsured than people who are considered not poor, which is above 200% of the poverty threshold. So this just shows that there's a correlation between underserved communities in healthcare access as well as their insurance coverage. Another factor that can affect someone's healthcare access is their occupational status, and this is in a variety of ways. But the ones that we touched on was that in America, insurance is tightly linked with someone's employment. So if they lose employment or they're between jobs, they may immediately lose those healthcare, the healthcare access that they have, or the job that they have doesn't provide them adequate health insurance. Another big factor of occupation is that some jobs, many jobs, don't offer time to go and seek care when you need it, whether that's because you just can't take a day off, there's no paid time off, or just the hours of the job could be from 8 to 5, 9 to 5, and you're really not available during the times when a lot of healthcare facilities are open. So there's a big issue with being able to seek care. And finally, we also talked about occupation is a health determinant because of the exposures and the physical activity that the job may give to you. So if we're talking about people mining or in a factory may be exposed to certain harmful particulates, or even people who work an office job and they're sitting all day, that leads to its own outcomes. And finally, we looked at health literacy and the prevalence of health literacy among underserved communities. And just to define what health literacy is, we said that it's someone's ability to really find and understand information about their own personal health, whether it's an issue that comes up or where they need to go to solve that issue or how to care for themselves after that issue. There's so many different aspects that health literacy is playing a role in. And healthcare or health literacy levels are lower in many underserved communities, and that can result in hesitancy to seek out care in the first place, which just perpetuates the issue itself. Also, lower health literacy rates can lead to lack of engagement with the healthcare system. If someone doesn't understand it, they may be less likely to engage with it and get involved, and thus their healthcare could just spiral, an issue may spiral down out of control. And one thing that I especially emphasize during class is that health literacy rates aren't just current issues. They're based on many of them are based on historical factors that were perpetuated among these either underserved communities or underserved populations, and this plays an important role in their health decisions. And one thing we touched on also during class is the COVID-19 disparities. To really making it pertinent to today, we can see disparities in medically underserved populations and communities, even by the rates of people's getting COVID-19, dying from COVID-19, or having adverse outcomes. Just looking at this graph from the CDC, we can see that certain populations have much more likeliness, have a much higher risk of being hospitalized, either getting COVID-19 in the first place, being hospitalized by it, and then even dying with it. So basically, with all these factors that we just described, healthcare literacy, the COVID-19 disparities, and all these others, we can see, we can describe what a medically underserved community is. So with those, we were able to get a good foundation for what public health is, the frameworks behind it, and how we're defining underserved communities. So then week 3, we started looking at the problems, specific problems, and specific solutions. So the first specific problem we looked at was the healthcare worker shortage, which is a tremendous issue, not just among medically underserved communities, but among everywhere. So this big number that we touched on is that the United States will face a shortage of up to 139,000 doctors in just a couple of years. And that big number shows that there's definitely big things we can do with improving education, increasing the number of doctors, but that itself at the current pace won't be able to solve the solution. That won't be a solution. So we need to turn to other things like technology to approach this fundamental issue. The healthcare worker shortage got even worse during COVID-19. A lot of problems that already exist have become exposed, or it exacerbated certain issues. We saw that ICU nurses who saw were typically in charge of a couple of patients at a time. We're moving up to 6 to 8 patients. There was a rapid increase in the patients and workers who had to quarantine, and the ICU capacity. There was a lot of conversation, especially at the beginning of the pandemic, about lower ICU capacities. And in many cases, that was not restricted by physical facilities, but just not having the staff to staff those intensive care units. So even from COVID-19, we can see what healthcare worker shortages can lead to. So then we talked about some technological interventions. And for the for this third week, we looked at two fundamental solutions, which was telehealth and artificial intelligence assistance. Telehealth is really defined as any healthcare that someone gets through an electronic device, that they're not having to go in to see the physician or their medical practitioner in person. Options include phone, computer, and then we looked at the benefits of this. So what does telehealth enable? First, rural communities, there's a much lower density of physicians, not just general practitioners, but even very specialized physicians are much less likely to be in the area of rural populations or in underserved communities like we described. So telehealth basically breaks a lot of those boundaries that exist so that doctors who maybe are in an urban setting are able to care for a lot of patients who are in rural or underserved communities. And this access extends just from the physical care, but to mental health care, which is becoming a bigger issue, and allowing people to get access to that easily is even more important. Before we move to artificial intelligence assistance, we just wanted to talk about the negatives. Later on in the course, we did touch on the negatives of all these technologies, but just to specify it right now, there are these positives of allowing these communities to get the healthcare that they need, but those issues that exist with not having the technical devices, the computers or the phones, is an issue. Not having the broadband internet, which is still lacking in many rural communities, makes it difficult to reach telehealth. And then going back to the health literacy issue, this doesn't solve the most fundamental health literacy issues. So a lot of problems persist, but this does incrementally increase the availability of healthcare to communities. Looking at artificial intelligence assistance, the one we focused on specifically was AVA. AVA was when I first learned about AVA, it really shaped my thinking in the role of technology in public health and in medicine. So when I learned about it, I knew that it was a fundamental thing to talk about. And basically what AVA does, it's similar to an Alexa device, a voice assistant that can be installed in patient rooms at hospitals or in doctors' offices. And it enables more communication to occur with the device instead of needing to offload or having it all go to the nurses or the staff or the physicians. So it offloads some of the most routine tasks away from the actual personnel and onto this device. So the AVA assistant, we talked about the example about how it can be installed in the hospital room, and then it can, for example, control just a lot of the simple tasks that might be necessary in a hospital room when someone is bedbound. They could control the TV, they can ask requests, they can ask for help, they can control different aspects of their room just with their voice. And this takes away from a lot of the things that the nurse might have to deal with normally, allowing the nurse to focus on their more important tasks. I mean, everything they do is important, but by taking away some of this more surface level stuff, you can allow the nurses to focus on really what their specialties are. And the way this addresses the healthcare worker shortage was that the nurse who could be spread thin will now be able to offload some of the difficulties to the device. This device also allows for automating repeated tasks. Common requests can be easily handled, and then even improving communication with the patient. So not only are you reducing the requirement for the number of staff that you have, but also you can improve those existing connections. And like we had during class, during week 9, we had a conversation with the head of marketing and operations for AVA, so you can watch that in the week 9 module. And then another part of artificial intelligence in healthcare that we touched on was diagnosis and treatment. So, for example, Google has the new artificial intelligence system where you can use the app to diagnose, or at least in a way notify you of any skin condition that you might have. And this goes back to the worker shortage. So you may not have physicians in the rural communities, but if you're able to offload some of those more intro tasks to technology, like with artificial intelligence, like diagnosing something, or even not even giving an official diagnosis, but even preliminarily collecting information and providing some context to the end user, to the customer, to the patient. It really helps with the workload that exists in the healthcare system. So that was week 3. Week 4, we then looked at the issue of access to health information. And this ties a little bit more closely to the health literacy issue that we were talking about. So health information is basically information about your health, about public health measures, and about prevention measures. Internet. So this is an overarching category, but we had to talk about it because the internet, when it was created, just opened up the doors for a lot of the technologies that we've been talking about. But it also specifically allows better access to information. It makes this access more affordable. Instead of needing to go up get a book that's really inaccessible, you now have it right at the search bar. It also increases the awareness for public health measures. So let's say, especially during COVID-19, when we needed to get critical information out to the population, the internet made it so much easier. Also, online surveillance for disease outbreaks. We talked about it later in the course, and I'm going to also mention it today later during the overview. But basically, because we can maybe track the searches on Google, when there's a spike in searches for coughs, we could be seeing the early signs of an outbreak of an infectious disease in an area. So really a lot of tremendous opportunities that came along with the internet. There are the issues with it, which we will talk about. One of those issues comes from social media. So if we look at the share of adults who use social media as a source of news, this is back in February 2020, you can see that it's extremely high in most countries. The United States is there towards the center at nearly 50% using social media as a source for news. And this is where the internet can start to become an issue. Social media, as we've seen from several studies and recent investigations, can perpetuate misinformation and disinformation. We saw again during COVID-19 that social media was used intentionally and unintentionally to spread incorrect information, which is an issue. But then there's also the balance of who becomes the mediator for this. And, you know, in this class, we did use some time for critical thinking, but this issue is beyond, I think, this is really just for a big critical analysis of who really should be tracking this information. Should we leave it up to the social media companies? Because that may not always work. We've seen changes, science changes so fast. So who do we really allow to control this spread of information? On one hand, we talked about the balance of allowing the free spread of information because we want to hear as many voices and as many perspectives as possible. When it comes to something as concerning the health of the whole population, you also want to make sure that more dangerous things aren't being spread around as truth. And who mediates that is, I guess, a bigger question that we can use our just critical analysis to think about on our own. Looking at the pros and cons with internet and social media. Pros, of course, improves ease of access to information. You can target information towards vulnerable communities. What that means is, let's say we know one community who may have lower vaccination rates, for example. We can use online tools and online advertising to target people with those specific characteristics with this very necessary information. And again, we wouldn't want to use this for telling people to do anything, but by targeting information to vulnerable communities, you can help them make more informed decisions on their own. And of course, it reduces the cost tremendously of sharing information. Instead of mailing things out and needing books, you can right there go and use existing infrastructure like your phone and Google. So looking at the cons that we mentioned already, just to summarize a few of them, there's the risk of misinformation, which is a large issue that can perpetuate many different issues. There's also not always equitable outreach because of differences in technology. We defined medically underserved communities and underserved communities in general as not having access to a lot of these medical tools, whether it's broadband internet or the devices. So there's the inequity that exists there. And then there's also the issue of self-diagnosis. If we put the tools in the hands of everybody, of course, it does empower everyone to be able to look more at what their issues are, but then it also runs the risk of people self-diagnosing something that they might think it's much worse than it is, or they might think it's not as bad as it is. So we want to make sure that we're keeping track and keeping account of how we're diagnosing certain issues. We also touched on briefly, I won't go into much of it now in this overview, but we also talked about online information hubs, WebMD, UpToDate, that enable not just the normal consumer, not only the normal patient to look up things, but even physicians who have to know so much can now rely on a more technological backbone in order to keep track of what's going on to the most up-to-date information. So that was week 4. Then week 5, we started looking at specifically COVID-19 and technology's impact on COVID-19. The timeline of the pandemic, technology has played a fundamental role in every aspect of it. We had, even at the beginning, COVID-19 testing, getting quick testing out that worked. And there was those issues that in the rollout, like we talked about during class, but still, technology, a big part of COVID-19 testing, then a big part in communicating those guidelines of how to handle this disease and this infectious spread. Then we talked about the tremendous fast development of vaccines that was enabled because of technology. Then the vaccine rollout itself, which was helped with technology, and then even just helping with the future of the pandemic. Quick touch on COVID-19 testing. We won't go in depth on it too much now during this overview, but we talked about the different types of COVID-19 testing, PCR, those rapid tests, antibody tests, and the role that each of those plays, and how technology helped with the rollout. We did talk about the innovation triangle, which I'm going to touch on quickly in this overview about how to balance speed, cost, and quality. And in testing, we saw that might have been an issue in some scenarios, but I'll get to that overview in a second. The role in vaccine distribution, a lot of the appointment systems that exist are through online portals, which makes it easy to find an appointment, especially when we have more centralized databases like MyTurn here in California, or vaccines.gov across the country. So this enables people to quickly find the closest place to them where they can get the vaccine, make an appointment, and know where to go when they need to. This, again, we're looking at the negatives of this. A lot of people in medically underserved communities don't have access to this technology. And that's why it's crucial to provide alternate methods for making appointments. And many states and local governments are doing that by allowing phone calls or just going into walk-in appointments. So having multiple options is always important, like we mentioned during class. Vaccine development, again, I won't go too much on this into this during the overview because this could take hours, but vaccine development was so important during the solution to this COVID-19 pandemic, and mRNA technology, having this mRNA technology in vaccines played such an important role in getting the quick testing, development testing, and rollout for the vaccine. So the innovation triangle, like I was mentioning. So this is a very important thing to look at whenever we're talking about not just COVID-19 technologies, but any technology. The innovation triangle, which there are some people who have other ways, other frameworks of looking at it, but this, among many people in the literature, approach this as a very good way of understanding how the trade-offs of technology persist. So in the triangle, we have cost, time, and quality, and you're constrained to just 2 of these. So if you want, let's look at time. You want very low time. So you really want to look at time as a crucial factor. And in the pandemic, it was a crucial factor. Getting vaccines out quickly, getting testing out quickly, getting distribution out quickly. So you need time. Then you look at the cost and then quality. So you can only get one more of these. So then we want quality vaccines and we want quality tests. So then we're going to look at quality. So we want time and quality, and that means that you're not going to get a good cost, and the cost is going to be high. And we saw that with the development of vaccines here in America. There was the Operation Warp Speed, which spent billions, tens of billions of dollars on getting those vaccines. Without the cost, if let's say we were trying to care about cost, you may have been able to get it quickly, so we might have had time and we might have had a good cost, but then the quality would have suffered, and that is not good. And let's say we wanted to keep it low cost and high quality, then that could happen, but then it would take a long time, so the time would be hit. So when looking at any technology, we can have two of the three, and it's always fundamental to, in each situation, look at what's most important. And many times what is most important is getting it quickly and having quality. So technology is going to cost a lot. The cost is going to be somewhere where you're hit. Unfortunately, a lot of times, and understandably because of the way that the system is set up, is that the cost also does need to be taken into account. So that's when we take a hit in the time that it takes for developing technologies, or the quality in the technologies that are coming out. So moving forward to health communication and how fundamental that was during the COVID-19 pandemic, not only television, but now online platforms allowed for physicians, trusted experts, to really get the message out quickly to people throughout the country, throughout the world. Like I mentioned, trusted experts sharing guidelines and sharing accurate information as things develop, because things change, guidance changes, our understanding changes, and the evidence changes, and the conditions change. So it's important to get out that information as quickly as possible, and technology, of course, enabled that. Vaccine passport. So this has become a very contentious thought here in America. It was implemented in other countries like Israel with the Green Pass, and that was very effective. And basically what a vaccine passport is that it's it could be a physical, like a paper pass, or a digital pass that you need in order to get into a certain facility. For example, let's say you're going to a basketball game, a Lakers game, you might need vaccine proof, and then a vaccine passport is what proves that you have gotten the vaccine. Like I said, this has become a more contentious topic here in America, but technology really enables vaccine passports and vaccine passes, digital vaccination records, to become much easier. For example, in LA County partnered with a company called Healthvana, so that anyone who got a vaccine in the county also got a digital version that can fit straight into their mobile wallet and make it much easier to deal with the record keeping of having a vaccine. And finally, that week, I pointed to this really wonderful article that was published in Nature Medicine about the different digital technologies that played a role in public health response, in the public health response to COVID-19. So I highly recommend, if you haven't read it yet, to go take a look at that. And there's two parts of that article that I just highlighted during class, which was this chart about the way that different technologies played a role in public health. So we had the epidemiological surveillance, so being able to surveil how the situation is for an outbreak like COVID-19, quickly identifying cases, communicating to the public the issue and the solutions to it, and then also the clinical care like telehealth and other ways of reaching out to those communities. And there's this chart, which again is available in the article and it's posted in the week 8 module and the week 5 module, that looks at how all of these different technologies come together to create this layered public health response. One of these technologies themselves is important, but when they all work together, that's when we can get really the best outcomes for individuals and for the whole community. That was week 5, COVID-19. Now we looked at, when we were looking at week 6, we looked at personal and community health tracking. This is plugged into so many different of the issues that exist in public health, and technology has really helped streamline the solutions that exist. So we'll first touch on personal health trackers. So those things, personal health trackers are things like health bands. So you have like Apple Watch or the Fitbit. And this is just like a very easy consumer way to improve someone's health. So tracking daily activity, tracking your heart rate, producing EKGs, ECGs, that really, when we're talking about giving power to the individual, this is one easy system that allows individuals to keep better track of their healthcare. And this could warn them that they might need to see their physician and guide them into the right steps of where to go in the health way, or even in just keeping preventative health. So getting the right exercise, standing up during the day. This simple system really enables new possibilities. Then another personal health technology, which this is, for example, in a future sense, the insulin patch. And this is something that was developed at UCLA, where it's a patch, low-cost patch that you can, it's a patch that you can just put on your skin. And it has these points that can keep track of someone's insulin levels and then also release the right, the necessary medication when necessary. We talked about EMRs, and I'm not going to touch on it too much now because in the future weeks of this overview, I'm going to be talking about it a little more. But electronic medical records allows for tracking of someone's healthcare in a portable fashion across physicians, across healthcare systems, across hospitals. So when someone sees someone at one physician and they go somewhere else, it's less of fragmented care, as long as the EMR systems are connected, which that's its own issue. But when it's working in the ideal sense, you reduce that fragmented healthcare that might exist. So you're decreasing the friction that exists and improving the healthcare outcomes for patients. Looking at community health tracking, we touched on multiple different ways that exists. Whether it's using these healthcare databases to glean important information, or using those fitness bands for research trials. So you can leverage this data that is easily collectible from fitness trackers, and without much friction. Again, reducing friction is fundamental in the correct implementation of any technology. With reduced friction, you're able to track large populations of, let's say you wanted to see the correlations of heart rate and someone's fitness, boom, you can easily do that. Let's say you wanted to look at the correlations between anything that the band can track, you can easily and anonymously collect large troves of information that allow us to more quickly produce the results and the evidence necessary for research trials. And again, the concerns of privacy and an individual's control over data is an issue that runs along all of these technologies. Particularly here, we want to make sure if people are being enrolled in these trials that we protect their privacy and we let the user really have the control over their own data. Week 7, we started talking a little bit about the opioid epidemic, such a big issue that exists in our country, particularly this year with COVID-19. The rates of death from opioids has gone up tremendously, unfortunately. We talked about it, and it's become a big... So finding the right solutions to this, to the opioid epidemic in any way possible is really vital. Oh, this was a quick COVID-19 update that we had. This was back in week 7, so I just left it in here to look at a quick overview about how overdose deaths were accelerating during COVID-19. Also on this slide, I had that Pfizer was preparing to seek full approval of the vaccine, and this was also the week when COVID-19 vaccine was approved for children between 12 and 15. So this was a pivotal week for the vaccines, but then there was still the bad news about overdose deaths accelerating during COVID-19. So looking at the epidemic, there's a lot of fundamental determinants that exist in this epidemic, and we're not going to talk about all of them today during this overview. But before I get into that, I was just going to talk about what opioids are. And according to the HHS, it's a class of drugs that includes illegal drugs like heroin and synthetic opioids, but also legal pain relievers by prescription, like oxycodone, hydrocodone, and morphine. They're helpful when they're used correctly, but when used incorrectly can lead to dependence, addiction, and overdose, which leads to very bad outcomes. And this is a chart, a little bit of an older chart from last year, but still the numbers are very bad. You can see tens of thousands of deaths that involve opioids and even prescription opioids. So there has to be a solution to this, and technology, of course, can play a role. When looking at the solution, we can see from these studies that many patients are prescribed opioids when it's not the best option for them. So it's setting up patients for failure. And looking at the technological solutions for that, we have EMR tracking. So we talked about how EMRs can enable better tracking of the health of a patient, but also it can allow us to make sure that if a patient might be switching physicians, going through different healthcare systems, we make sure that they're not being overprescribed prescriptions. So having this consistent technology, this record for a patient across different systems allows us to keep track of opioids to reduce that risk of overprescription, reduce it in some level. Of course, not completely solving it, but anything that can help. Also, looking at a solution that California has implemented, like Cures 2.0, this is a statewide system that allows physicians to input the opioids that they're prescribing so that we can keep track of that. And the technology enables quick input of that by physicians and the quick tracking of that so that we can have a sense of how things are going, who has the opioids, and where we stand with that. And this new version of Cures really stresses the importance in response to the high rates of addiction and overdose. Another aspect of it, of course, is physician education. So physician education around opioids has transformed a lot over the recent years, as we've seen. So technology enables physician education, not just for opioids, but looking at it more generally, for physician education much quicker. So instead of physicians needing to go to conferences to get the latest information maybe once a year, we can provide more frequent updates through teleconferences like we've seen this past year during COVID. Zoom allows for these quick meetings and this updates to information. So physician education has been fundamentally changed through these online modalities. And then it also enables, for example, modules that we can have physicians go through every certain time points to make sure that they're up to date with the most recent guidance on how to use and how to prescribe opioids. Then we have the development of naloxone or Narcan, and this allows for the undoing of an overdose. And there's some caveats to it where, after a certain period of time, if they're not treated with more medical care, they can go back to the overdose. But really, the development of this was a big leap in the field of combating overdoses and getting more of this Narcan out into the community where those problem spots are will help be a solution to this rising issue. And with that, that was our coverage on the unit of the opioid epidemic. Then we targeted on some of the barriers. And this is the barriers to healthcare access in the first place, which we touched on earlier in the class, but we looked at it a little bit more in depth here. And today I'll touch on it in the overview and then also technology adoption. So barriers to access, we have transportation. So many of those in underserved communities may not have a way to get to those healthcare facilities, whether that's not having their own vehicle, not having public transport that goes to those healthcare facilities. And that is a big barrier in getting healthcare access. Another one, cost. This goes back to what we were saying about insurance. So even if they do have insurance, a lot of people may be unable to afford the healthcare that they need, let alone having the insurance. Stigma. So in many cases, people are afraid to seek help for certain issues because of stigmas among their community or among the general society. So that itself can be a barrier. Then time. Not having the time to get help is an issue. And a way to solve that could be having healthcare available at times that aren't in the normal 9 to 5, but then also looking at telehealth. Like we mentioned for telehealth, you don't need to go directly to the doctor. So this can allow for more flexibility for times that aren't in a typical 9 to 5 job. And finally, the facilities. There just may not be those facilities, those healthcare facilities in underserved communities, and people would have to travel further, go somewhere else, and that itself is a barrier. So that's barriers of access to health, and now we're touching on barriers of adoption of these new technologies. So it's all the theme of barriers, but two different aspects of it. So barriers to adoption of technologies. We touched on a lot of technologies during this overview today. What's the challenge to getting these actually into the communities? First, the cost. It's very expensive in many cases to get technology implemented in communities. So that it may be targeted where it's more cost effective to do it, or where there is the capital to implement them. So in these lower income communities or these underserved communities, there may be this lag that exists in implementing new technologies because of the cost. Then proximity. So this is newer in the literature, talking about the distance to innovation centers. So an innovation center would be something like Silicon Valley, where a lot of the new technology comes from, or even Los Angeles, San Francisco. The further that communities are from these centers of innovation, the less likely they could be in having the implementation of the new technologies, just because they're further from the places where they're developed and where those companies are, where they're beta testing it, and where they end up rolling it out initially. Time. So time itself is a barrier. If there's an uphill climb in implementing this, and you see it's going to take a long time, the companies would be a little more hesitant in implementing the technologies in underserved communities. Then there's hesitancy, and this is a very nuanced topic of hesitancy to technology adoption. The way we covered it in class was looking at how some communities may be hesitant to new technology coming in from outside the community, whether that's concerns around privacy of this new technology, or just a lack of trust in this technology, concerns in how it's being implemented. There could be this feedback from the community that they don't want to have it, and then that just delays the installation, or even just the implementation may just never come. So, and that's a very nuanced issue that is evidence of how important it is to, when we are developing these technologies, we really hear the voices from the patients and the consumers and the members of the community that are going to be benefiting from this, because we want them to have a say in how the technology is implemented, how it's developed, and that way we'll have more likelihood of it actually being successful. We spent a lot of time in class talking about the importance of a voice in the development of technology. I won't spend much time on it today during this overview, but just to stress, incorporating the voices of the people who the technology is seeking to help is vital in having the successful technology. So one technology we looked at in the solution to transportation, for example, the barrier of access of transportation, was these new transportation apps like Uber and Lyft, or relatively new. And there's so many ways that they are impacting the field of healthcare, which aren't as obvious as some of their normal operations. But for example, if we look at the most surface level, Uber and Lyft offer an alternate way for people to get to healthcare facilities if they don't have access to public transport. Taxis might not be available, may not have their own vehicle. Transportation apps offer just another way for people to access these healthcare facilities and get to where they need to be. But also there's lesser known ways that they're helping, such as prescription delivery. So if we look at the difficulty that people have in getting prescriptions, for example, they may go to the doctor, they may get their prescription, they may have been diagnosed, they know exactly what the problem is, but that last mile step of just getting the prescription could be a challenge and may delay their care. So making it easier by having it delivered to your house through Uber or Lyft just takes another step of the challenge of healthcare away and reduces the friction, and reducing the friction improves the outcome. And also, like we saw for the vaccine rollout, Uber and Lyft are having free rides to any vaccine center across the country through July 4th. So there's just another way that this new technology of the transportation app is enabling a free form of transportation to vaccine centers to help increase distribution and the uptake of COVID-19 vaccinations. And finally, during that week, we touched on mental health technologies. So mental health is in many ways just as crucial as all these physical health solutions. So there's many ways that mental health has been impacted by technology, such as mental health applications through artificial intelligence. So there's some apps where people can register their moods and their feelings during the day, and it can provide advice, or it can, in a similar fashion to telehealth, connect users to therapists or any of the psychological help that they might need, a meeting with a counselor. And also it enables a new form of communication with people, with the therapists or the counselors, like messaging. So especially with a younger population, they may feel more comfortable. It may be a little difficult to face or even through FaceTime or through one of the phone call solutions that exist in these applications. It may be tough for newer generations to do that. If they're more used to messaging, these apps provide a messaging solution, which might make them more comfortable. Obviously, in the long term, it would be ideal to have the face-to-face conversation, but this can be an entry point to make people more comfortable with seeking out the help, the mental health care and mental help that they need. And a summary of these negative effects, we mentioned multiple times, but this was something I stressed throughout the class and that I wanted to include again in this overview is the negative effects. Not everything is positive that comes from these technologies. There's the risk of the breach of privacy. There's the cost to consumers. There could be inadequate care in telehealth. You may not be getting the full solution. And there's the lack of personal connection. A lot of healthcare is not just what you go to the doctor for, but the other things the doctor can provide to you, what the healthcare system can provide to you. There's that connection that you develop, the bond, which is a lot easier when in person. And finally, looking at the outcomes. So here's week 10, a summary of some of the outcomes that we had in this course and of this overview. The health frameworks, the ideas for innovation, and the final project book. So we'll just go through each of these quickly. We have the frameworks that we talked about, the ecological model. There's the different levels that your intervention can target. For example, let's say you run a campaign where you're targeting people to tell their friends, their immediate close friends, to get the vaccine. That would fall under the interpersonal section of this ecological framework. And just a side note on that we mentioned during class, a lot of times trusted friends, their voice matters a lot more than what an influencer or a celebrity might say. So having targets towards interpersonal interventions can really lead to some fantastic outcomes. So that's the ecological model. Looking at the innovation triangle, we talked about, just to review, the three components: cost, time, and quality, and that you can really only strive for two of those. It really can result in only two of those. So having the tough balance of deciding which ones to focus on, which may vary among technologies, and understanding that this framework is fundamental to applying when looking particularly at healthcare technology and the value of people's health, and having the trust and the quality really shows the importance of this triangle. Then we had ideas for innovation. I'm not going to run through this, but these are images of the jam boards that we did, some of the jam boards that we did during class, where we shared our ideas. We split up into rooms, and we talked about the ideas that we had for different solutions, such as how to improve vaccine uptake and reduce vaccine hesitancy, or new ideas for mental health strategies with technology, or how technology, the pros and cons of how technology could be implemented in the workspace. So one outcome of this was just understanding not just the framework, like I mentioned, but understanding the critical thinking of understanding all the facets that exist and that you must balance when you're looking at a technology. And finally, the innovation book. So as you all know, we are having, everyone is writing one chapter for this book, the innovation book, ranging in a wide variety of topics that we covered in class and that are extrapolated from our class, ranging from telehealth, virtual reality, robotic surgery, autonomous robots, vaccine development, social media, just a wide range of topics. So this book will be put together and we'll have a nice digital ebook that summarizes the approaches, the technological approaches to solving issues in medically underserved communities, as well as the pros and cons to each of those and where they fit in the ecological model. And with that, thank you all for a fantastic quarter. I really appreciate all of your great ideas, all the discussions that we had during class, every new perspective that each of you brought from your unique backgrounds really added to the conversation and really added to the class's perspectives on these topics. Because like I mentioned, technology in public health is a very nuanced issue, and we always want to take into account what everybody has to say when we're implementing new technologies. So once again, thank you all so much for a really great quarter. I appreciate everyone's contributions to the course, and I hope this overview was useful in really tying together all the thoughts and all the concepts and all the topics that we talked about during this past quarter. Once again, I've been so honored to be able to teach this course and for all your time and effort that you've put into this course. Thank you all so much.